I'll hit the record. Okay, here we go. The first case for discussion. A 65-year-old male comes to the urologist with prostatic enlargement. And this urologist is a very busy person, got a lot of patients coming to his clinic. He likes to see several patients one after another, but he only has, I think, one or two exam rooms and so forth. When this patient comes, he does feel the enlargement. There's a little bit of elevation of PSA, and so he performs 12 needle core biopsies as is his routine, the different quadrants and so forth, and then sends those to the pathology lab in 12 separate bottles. 2 days later, he gets a report back with a diagnosis of prostatic adenocarcinoma, Gleason score 3 plus 4, that is present in three samples on the right side only. And the largest of these is uh, about 5 millimeters in maximal length. Okay, let's see if we can find the advance the slide button. Okay, so here's what that might look like. This is not actually from the patient, but just an example of what Gleason pattern 3 looks like. Closely spaced back-to-back glands, a little bit of luminal secretion and some crystalloids here you can see. And then a Gleason 4, less well-formed glands, a little bit of cribriforming, maybe some slight clear cell change. And the Gleason pattern 3 was the dominant pattern. The 4 was a minor component, so it was given a Gleason 3 plus 4. Okay, so here we go with the discussion. What are the implications of this diagnosis? Would any of our participants like to say what they think the likely treatment and prognosis for this patient is? Dr. Trent, how would this patient be managed in Hue? Do you have any ideas?
Yeah, I actually don't have any idea.
Okay. Um, well, usually a tumor of this size, less than 5 millimeters in maximal dimension and only in part of the gland, that would indicate that the tumor is probably confined to the prostate. If they did radiologic studies and determined there were no lymph nodes that were enlarged, this patient would probably have a radical prostatectomy. Now, the sample came in 12 different parts, and in the laboratory, those 12 parts would usually be handled as a single patient. And the person doing the gross evaluation might line up the 12 different bottles and 12 cassettes, maybe with some sponges to help them keep them inside the cassette and so forth. So they'd be managed individually. One specimen moved to the cassette, closed. The next specimen opened, moved to the cassette, closed. Next bottle opened, moved to the cassette, closed, and so forth, with the appropriate gross description being handled as they went along. Now, in some laboratories with these very small needle biopsies, they do some additional things to make the sample more visible in the paraffin block. So in some laboratories, they might apply some India ink to the tissue core to make it stand out a little bit more when it's in a paraffin block later on. And that can be useful to help them to make sure that they get a complete section. Other things have been devised to manage these sorts of specimens. They're a little bit more costly, but you may read about them in some settings. And I don't know, maybe some of my colleagues have used these samples, but there's what's called the a biopsy chip, which essentially provides a slotted container in which you can insert each of the 12 samples in a specified order that is standardized between one patient to the next. And then that cassette, or then that template can be put in the cassette, processed through the processing, and actually embedded because the intervening septate areas between those little slots is sectionable and helps to keep them in place. I don't know, Kamaljit or Esther, have you ever seen or used that biopsy chip in your institution?
No, I mean, no. And the only thing I can recall something similar is when they're doing the breast biopsy. So they have this container, it's like a round de container which has the clock positions. So, and then they put these cores, and so there's a round disc-like thing, and then they will put the cores on the disc, and they are labeled as like 1 to 12 o'clock. And
Okay.
that's something that we do in breast.
I
So,
oh,
oh, Esther?
I haven't used them, but I've heard about it. My friends use them in different institutions, but I don't think it's very common because they're expensive, and I don't know how frequently they're used in centers that's smaller in size.
Yeah, yeah. I think they're not very prevalent, although the cost is actually not, the cost to make them is actually not terribly great. And I was speaking with one of my friends who works with the company, and they're actually looking to manufacture those templates in uh, Vietnam or in India, other lower resource settings. So they may become available in some additional way sooner in that setting, where if they're manufactured in the one of the countries where we're involved. So there's been a lot of talk here about using special diagnostic tools with prostatic biopsies. So while the diagnosis with the images that we just saw would be fairly straightforward, in many laboratories, they're beginning to use uh, um, artificial intelligence to both quantitate and measure, as well as provide a sort of second check in terms of grading uh, for these images. And so that can be an additional um, tool that is used in some places to enhance the diagnostic acumen of the pathologist. Immunohistochemistry may be used fairly routinely, and in that situation, they're looking for markers that distinguish the cancer from non-cancerous glands. That's usually not a problem where you have high-grade tumor, a 4 or 5. It's more the grade 3 tumors that can be small and difficult sometimes to detect. So just a little bit of added information about this process currently. I don't think AI is being used in more than 10% of the laboratories in the United States currently for this disease. It's still fairly limited, but it is growing, and there's a lot of work being talked about in that regard. So this patient had a prostatectomy. And in terms of grossing the prostate, the picture here on the left is what the resected and fixed specimen might look like. Probably here looking posteriorly because we have the seminal vesicles up here. And obviously, staging, invasion of the tumor into the seminal vesicles ups the stage, as does any penetration beyond the capsule. So, this sample, this prostate, would probably be painted all over in ink. And I think here you can see in the sectioning that this does have a little bit of a black rim around it here. Now, we section it usually from cross sections going from the apex, the distal portion, on up to the base of the bladder. and you can see that's what each of these sections represent. Now, this is not actually from this patient because this lesion has a mass lesion here you can see on the right, which is slightly different in color. And coloration and texture is very important, but not infrequently in the prostate. We have areas of nodularity, variable appearance, and so forth, and we may not be able to grossly detect where the cancer is that we're looking for. And so in many circumstances, we do end up submitting a large number of sections from a prostatectomy to properly identify where the tumor is located. Now, I realize that in Southeast Asia, the prevalence of prostatic disease, prostatic carcinoma, is considerably lower than it is in the United States. That's undoubtedly due to a combination of diet as well as genetics. It may, in some circumstances, be related to a higher soy content in your diet or other factors that seem somewhat protective from the development of prostatic disease. But anyway, it's nice to sort of expose that. So, what happens to our patient? Well, his final diagnosis reads like this: a prostatectomy, only benign hyperplasia, hypertrophy, no evidence of malignancy. And then, as if answering the surgeon's question, did you get the biopsy wrong? No, we reviewed the prior biopsy, and the diagnosis of adenocarcinoma is confirmed in that sample. So here's my question. What do we do now? Do we have to do anything more? And what sort of explanation might there be for this apparent discrepancy between the biopsy and the resection? So would anyone like to sort of chime in and offer an opinion? Don't be shy. There's no wrong answers. So I'm going to call in one of our other mentors. I think Dana, you joined us as well. Are you here?
Hello, I am here.
So,
Yep.
so what would happen in your institution if if you had this situation develop?
Yeah, so this has happened in two places I've worked now, once with the prostate, once with the breast. And they it's taken very seriously. You need to make sure that the prostatectomy was adequately sampled, if not entirely submitted. Make sure you're not missing that cancer would be step number one, I think. And in the case of the mastectomy that didn't have cancer in it, that was also done. And then you would review all of the biopsies that were done that day, all of the other prostate biopsies that were done that day at grossing. You would want to review those and see if everything's matching up. Same thing happened with the breast. There were 4 breast biopsies that were submitted that day. And then another thing you look into is in the case of the breast, you can look at the molecular data that comes out of that. If that's done in your country, match those up. And you would want to match up the final diagnosis of the other specimens that happened that day. So if you had a mastectomy in a person that had a benign lesion resulted, but the clinicians knew that, oh no, this is definitely cancer, and they still did the mastectomy, and that person ended up having cancer, if they had the benign biopsy and vice versa, then you're gonna be your degree of suspicion that something might have been switched raises. In the case of the breast case, the patient was tested. The genetics was tested on the biopsy and the final mastectomy, and they did not match the patient's buccal swab. So there was confirmed that there was a switch made in, actually, that turned out to be radiology. So, but of course, in our department, pathology had to really investigate. Some places use gross cameras, so that's really helpful to be able to review the actual grossing. And of course, you're looking at the requisitions and the labels on everything, the cassettes. You're going to pull everything possible from all of the cases, and you're going to examine them thoroughly. So yeah, then if you can't find anything in pathology, you need to go back to the people that took out the sample and examine their practices. So it's a really big deal when these things happen.
Yeah, I think you really underscore the fact that you don't just rest with this process. This is what triggers a quality investigation, and it does so because uh, very often when there's any sort of a switch, it's not just one patient that's affected. There may be a second patient who's involved, and you don't want them. So let's see. So here's where we can just sort of classify where the mistakes can happen. Uh, this is based on your understanding of the workflow. So you mentioned the before the specimen arrives in our department in the laboratory, there can be a mix-up, mislabeling of the specimen or the patient, misidentification of the patient either in the office or even maybe when you're picking a name off of a computer list or something like that. Those are really critical times to make sure that the correct name, date, identifiers are on that specimen and they correspond to the actual patient that you're working with. Then, as we go through all of our processes, there are a number of situations where the tissue is maybe momentarily dissociated from its identification. So, at the gross bench, as it moves from the bottle to a cassette, that is a critical transfer. And you want to make sure that that happens with just one option. The one bottle is open, one cassette is open, so that you're not going to put it into the wrong location or get it misassigned in any way. Likewise, when it comes off of the processor and it's coming from the wax bath and so forth, going into the next cassette, you want to make sure again that the right tissue goes into the cassette and nothing extra. Similarly, at the time when we're cutting that block, the tissue comes off the block onto a water bath, and then it's picked up with a slide. Well, you got to make sure that that slide represents is labeled with the right patient name and right patient identifiers. Then later on, it's put together with a requisition or some sort of paperwork, perhaps, and then assigned to a pathologist for review. So you want to make sure that the paperwork and the slides match up. Because that can then lead to, a mistaken identity or mistaken assignment of a diagnosis. If the pathologist is a little bit lax and just looks at the paper, doesn't look at the label on the slide to verify that those match up, they could make a mistake at that stage. Similarly, when you're dictating, if you use a dictation system, you can enter the wrong number in the dictation system, perhaps, and then that may be transcribed onto a different patient's record. So all of those are things that can happen within the laboratory at the time of evaluation. Post-analytically, can be charting errors, again, transcription errors, those sorts of things where the wrong report gets in the wrong chart in some way or another. So all of these become potential sites for investigation, but we usually begin with the areas where we have the most control, and those are the ones in the laboratory, the analytical variables. So what did we do in this case? We looked at the case logs from that day of biopsy. We looked for all the prostatic specimens. We looked at the worksheets from the day of the biopsy and what order those samples were processed in. Were there any two cases that were similar, that were one after the other, sequentially, either at accessioning or embedding or cutting or anything of that sort? And these really are things that need to be done urgently because, well, two reasons. One is the longer you go with the mistake sitting out there, the greater the risk that the patient becomes angry or upset, that you'll end up in some legal problem. And likewise, could be someone else out there who is potentially about to get either the wrong surgery or the wrong diagnosis. Now, the same sorts of issues happen with other laboratory results outside of the tissue exam, and in some situations, they're even more urgent. So if by chance you happen to be involved with the blood bank and you have an identification error in the blood bank, that is a real emergency to track down and make sure that you don't have the wrong blood going to the wrong patient another time. So that's another important sequence to be aware of. So what did we find? Well, in investigating the grossing sequences, there were no two prostate biopsies that were handled sequentially. Likewise, at the embedding sequence, no two prostate samples were handled sequentially. At microtomy, there were two patients who were handled sequentially, and so that's a possible consideration. And then at case dictation, you note that the prostate biopsies were handled by two different pathologists. But this particular case was the only prostate case done by Dr. V, and all the others were done by Dr. M. So it's not a case dictation or a case assembly issue, as best you can tell there. Well, you go a little bit further because we haven't found a source for this, and so we look at where these specimens came from. And on the particular day of that sampling, we saw that there were 6 prostatic samples submitted. Only 2 of them had cancer. The particular case we're investigating, and one other case, but that was a Gleason pattern 5. So that would be very unlikely to have been missed in the resection. And so that's unlikely that that was swapped over. We do see, however, that there were some other benign diagnoses from urologist A. So we need to then think about could there have been some labeling or sample mix-up here in urologist A's office? So how do we do that? Well, Dana mentioned the molecular issue. And this is an expensive process. It's not something that insurance is going to pay or that you should bill to the patient. But it does allow us to take the tissue on the slide and do some form of identity verification. This is most useful to compare 2 samples, so such as the biopsy and the resection sample. And this uses a DNA extraction or looks at microsatellite analysis or maybe single nucleotide polymorphisms. And from that, you can detect whether 2 pieces of tissue are from the same person In other words, they match in terms of microsatellites and polymorphisms, or whether they're from different people. So what did we find? Well, the samples, not surprisingly, from the biopsy and from the prostatectomy sample did not match. Because we were aware of the other patients from the same office, we determined that it might be worthwhile to likewise use those as comparison samples. And so we compared those other 4 patients to the prostatectomy. And lo and behold, the the prostatectomy sample matched the sample from one of the other biopsy donors that had been seen immediately following in the office, and had a sample that matched the benign prostatectomy. So then the question is this biopsy sample from Mr. CP really his? So, or does he have cancer? So with that potential swap, patient CP was called back. A repeat biopsy was performed with greater care. And in fact, it did show an adenocarcinoma similar to that seen in the what was originally thought to be RM's biopsy. So, fallout from this investigation, certainly in terms of patient management, which is the urgent thing, Mr. CP is going to need some further treatment and probably needs some explanation as to why his initial biopsy was called benign and now the second one has been called malignant. And patient Mr. RM, he needs an apology and potentially some compensation, maybe some relief or dismissal of his hospital bill or surgical bill and so forth, because he was treated unnecessarily. So there's a variety of issues here that come up to be thinking about. So because of this, I just underscore again that when we have a patient identification error, oftentimes there's a second patient as well. It's usually a switch rather than just a single patient who's been misidentified. So one of the tools that we can use to identify how this happened is to begin to do what's called a root cause analysis. And sometimes that takes this form of a fishbone diagram, where we look at the people issues, the methods, the materials, the equipment, environment, the nature, and so forth, our measurements and so forth, just to see were any of these factors contributing to the development of this problem, the misidentification of a patient issue. And in fact, when we started to do that in the doctor's office, we discovered that the office assistants often felt very rushed on busy days, and so they pre-labeled the biopsy sample bottles with the patients who were scheduled for that day. And then they put all of those bottles into the room. So by asking this question of why were the samples labeled with the wrong patient name is because multiple sample containers were in the examination room. And the reason they were in the examination room is because the office assistants were rushed. They pre-labeled things, and then things ensued. Well, as a consequence of this discovery, we began to promote the idea of a timeout. And that's a timeout is very commonly used in the surgical suite, where they verify that they have the right patient, that they have the right site, that they have no other patient materials in the room, and so forth and so on. So they take that little time out to do that. Well, the same principle can apply in the office or in the other procedure suites. And we, as a consequence, recommended to all of our contributing clinicians that they do that timeout and that they verify that there's no other paperwork, no other sample containers that are in the examination suite at the time of the procedure. So, as a consequence of finding that out, when we then came to the patients, we had something to say, this is how we've improved our process to make things better. And really, this underscores the fact that when we find a problem, this is an opportunity. When we discover an error, it's an opportunity to improve our process. And that happens if we, first of all, make the disclosure of errors or near misses uh, be seen as not something for which we're going to blame people or shame them, but rather as a great opportunity. What can we learn from this opportunity? How can we improve as a consequence of this? And it's usually not just be more careful or make sure you don't make that mistake again. It's usually something in the system, in the process or the procedure, like a timeout, like only one specimen in the room or one patient label sample in the room at a time. If instead some people in some situations, they'll try to, put more checks in the process and say, okay, you got to, after the patient has a sample, you have to check it again. Well, that's adding work, and it works much better if you just do things right from the very beginning. So this has led to a whole new science of industrial design that makes it impossible for people to do the wrong thing, such as these plugs. These plugs, for example, there's only one way that they can go into the socket. And there's only one type of plug that will fit in that socket. So you're not going to be able to use that plug and put it in the wrong kind of socket. Well, that principle of making it only one way that works really does apply also to pathology when we start to think about it. If there's only one way to do it right, it will be easier for us to do it right rather than to make mistakes. So, what about this issue of disclosure? And maybe I can ask my colleagues, have any of you ever been part of a disclosure experience with a patient after a mistake has been uncovered?
No, not yet, Dr. Hassel.
You're lucky.
I think I can remember a couple of instances, but I didn't. It was involving the whole hospital actually. So depending on how critical or how early the mistake were caught, I don't think. Well, one incident was breast case, and I think it was disclosed to the patient, but I don't have experience of doing it myself or being witness to how it was done because it was done the mistake was in surgery. But before, I think the hospital was meeting with a patient, any people who were involved from surgery to pathology to radiology, we all had to have a meeting with the board and just also the legal team just to make sure to do the thorough root cause analysis and how to present it to the patient. So I think it depends on where you practice. It might be a little different approach, but they want to get all the facts straight before they talk to the patient. But I haven't been in the upfront with a patient or seeing how that was carried out with a patient.
Yeah, I think this is something that is evolving over time, and no one ever talked about this when I was in medical school. Um, and in fact, I can remember, unfortunately, a very significant or potentially significant error occurred when I was involved, and I was the medical student involved with the wrong drug being given to the wrong patient. And so it was reported to the attending and so forth, but there was never a discussion with the patient as to what had happened and why and how that would affect them, which I think was, in retrospect, probably a mistake. I think you're best when you go to the patient with all of the facts. If you just know a part of the piece, so for example, we've discovered that, your biopsy is not the one that belongs to your prostate. You can begin with that and say, we're still looking into this, but this is what's happened, and we want to apologize. We're doing further investigation. But certainly at the point where you have more or less complete function, you need to close that loop because, one thing that makes patients worried is if they've suffered something without any benefit for others. If I've suffered something and I see that it is going to benefit my children, I can say, okay, that was worth it. If I can see that it's going to benefit other people or my community, okay, I'm willing to accept that. But if we don't see that that's begun to happen from this sort of a process, it becomes more embittering for us. And our response is, well, somebody should pay, because I've suffered this and, no good has come out of it, sort of thing. So that is why the disclosure should include both an apology and whoops, and also what corrective actions, I said not what correct, also what corrective actions are taken so that others are not damaged by repeat of this error. So if we can see that there is good going to come for others, benefit, then it becomes a little bit more palatable to us. So just in terms of, in general, avoiding mistakes of identification, we've identified those key stages within the laboratory where tissue is momentarily dissociated from its identifier, either the cassette or the biopsy bottle or whatever. And that's where this concept of single piece flow comes in, just doing one case at a time, one sample at a time, one slide at a time, and verifying that those are labeled according to that. It seems to a lot of people that batch testing makes a lot of sense. Oh, I can just do all of these while I have my pencil in my hand, or I can do all of these while da da da. That is a setup for making a patient switch or a sample switch, and you don't want that to ever happen. That's why these should really be called never events. There also is very commonly, we're admonished to use two identifiers. Patients can have similar names, they can have similar sounding names and so forth. Numbers can be inverted. Various other sorts of things happen. And so using those two identifiers is very important. Where I trained, the accessioning sequences were also associated with a randomized check letter. So we had a numerical sequence of cases, but because people have this dyslexic tendency sometimes to switch terminal digits or a couple of paired digits, we also assigned each case a randomized letter. So it was, 1982-B-1234. And then the next case was 1982-X-1235. Well, if in some situation somebody had switched the 3-5 with a 5-3, that check letter was an extra guard, I guess you would say, to not assigning that to the wrong patient. Likewise, in terms of grossing and dictation and so forth, sequential numbering of similar case types is a potential risk factor. And so this is a problem in some large, busy private laboratories where they get lots of GI biopsies, lots of prostate biopsies, lots of GYN biopsies. It's very easy for all the cervical biopsies to be bunched together or all the gastroscopy biopsies to come together. And so it's sometimes impossible to mix those up totally. But if it's possible in your general workflow to assign those to different people to gross or do other sorts of things that can help them to avoid that sample mix-up, that's also a desirable workflow to avoid mistakes. And obviously, avoiding mistakes may seem a little bit of extra effort, but it's far cheaper in the long run than encountering one of these errors. Okay, so any comments or questions on this case? We have just a couple of minutes for this less complicated case before we go on. Either questions from our participants or comments from the other mentors.
I just wanted to say the word floater. I think we see that very common in my practice in gynae because we have all the endometrial biopsies. So the word, I think most pathologists are aware of the word. So something that we call floater is a piece of extraneous tissue that doesn't belong to the patient, and we see it in that section or on that slide. And then there can be multiple sources of that floater. Either sometimes, the techs are, busy, they embed somebody else's tissue. So it can happen during the embedding or during the processing. So something to keep in mind in the terminology of floater. And I guess it can be very difficult sometimes. Sometimes it's easy to identify a floater that this separate tiny piece doesn't belong to this patient. Like we get a lot of placentas because we process a lot of placentas, and we will have little placental tissue in a gynae, sometimes in breast. So that's easy, this is a floater. But sometimes it can be very difficult where you have a pathology, a tissue tiny fragment with a pathology that can happen in the patient that you're looking at. And all you have to do is kind of then what Dr. Hassel mentioned, try to go back and look at all the steps and match a case before or after who embedded it, and look at the log of the cases. And if that doesn't answer, then, and if it's a question of malignancy, then you go to the molecular testing.
Yeah, that's a very common situation. And yeah, having those logs of who embedded and cut which cases can be very useful in sorting that out, because if they had a similar case or a case with that malignancy in it or whatever that doesn't seem to fit, that's very helpful to sort that out. All right, well, case two is a little less complicated, as I said. So she's a 45-year-old woman, still fairly young. She has abnormal vaginal bleeding. She has a endometrial biopsy, and it has a malignancy there. So generally, endometrial malignancies now are evaluated to characterize them a little bit more in terms of molecular processes that are likely to be involved. And so she has this sequence of immunohistochemical stains that are performed. Estrogen and progesterone receptor, which are both 4+, P53 staining, which is found to be overexpressed in virtually all of the cells, and P16, which shows only patchy staining. So, is this a problem? Esther, if you saw this, what would you do?
A little young. Without seeing the histology, I mean, it could happen. So, I mean, she's a little young, but if that's the biopsy shows, then I'll look at the radiology, and if there is she has clinical history, and if this is her first sample, I don't know. I feel like I'll sign it out as malignant.
Okay, sorry to put you on the spot there. Okay, so here's her endometrial biopsy. It's generally fairly low grade, well-formed glands. It doesn't have obvious serous cancer characteristics, although, yeah, maybe those nuclei are a little bit, a little bit pleomorphic, but they're still fairly basal. So, well, what do I do with that? Well, I think this is one of the areas that's very controversial sometimes, but it does point out the fact that you need to be familiar with how your stains are working and what your expected results would be, and to make sure that you have properly validated things. So, overexpression of P53 is very highly associated with a TP53 mutation, and by conjecture, then, would be usually seen in a diagnosis of serous carcinoma of the endometrium. So there are some endometrial carcinomas that can be P53 positive. But the other feature here is that 4 plus estrogen and progestin staining is pretty uncommon in TP53 mutated cancers. Additionally, when you have a TP53 mutation, you usually also see very strong P16 staining. Now, I generally do the P16 staining to help me avoid missing a setting where the TP53 mutation is what's called a null mutation, where instead of overexpression, you get no expression of the tumor. And then, as Esther indicated, this is a bit young for serous carcinoma. It's possible, but generally serous carcinoma is usually 10 or more years post-menopausal that it shows up. So, she's 15 or more years ahead of the curve there. So what should we do? How should we evaluate this? And what results or what could explain these results? Well, as we think about how we troubleshoot staining issues, we have to ask, what sort of a validation did we do of these stains? So, is the estrogen and progesterone overexpressed because we have some, high titer of those antibodies in the stain, or is the P53 overexpressed because we have too high a titer of that? What did the validation studies look like for those markers? And in general, validation standards for doing a particular stain have been recommended by the CAP. There's no absolute, you've got to do it this way and so forth, but obviously the more samples you test that have reliable results and have been compared with another validated laboratory, the more reliable and the more faith you can put in your stains. Now, antibodies come in different lots, and so every time we change lot numbers of our reagent, critical variation there, we have to do some verification that the new lot is going to perform at the same level as the prior lot. And then we want to look at our controls. Are our controls appropriate for the intended purposes? Now, these staining abnormalities or aberrant stains can be either in the false negative situation or in a false positive situation. And in both circumstances, the control staining, especially internal controls that are within the tissue itself, can be very helpful. So, in addition to the epithelial component, there is an internal control within most endometrial biopsies, and those are the stromal cells. So the stromal cells also should stain for hormone receptor, as should the epithelial component if it's going to be truly positive. But there's not usually a good internal control for P53, except that the stromal cells there should perhaps stain only sparsely. They should have a wild type stain. and they shouldn't have abundant positive stain. So if you were to see the stromal cells also staining diffusely with p53, you might suspect that your titration was wrong, or there was some other fault in the detection system that was leading you to a false positive situation. The other variable that's involved here is what's called antigen recovery. And this is a really sort of an interesting story, but we're almost out of time, but perhaps another time. But a variety of methods that include steam and microwave or other sorts of methods have been done to break down some of the cross-linked protein bonds in fixed tissues to allow the antigen to be more recognizable. And my good friend Dr. Shi was a fellow at Mass General at the time he developed that technique, or actually went on from Mass General to develop that technique. And it has become fundamental to the utility of immunohistochemical stains throughout the world. So that's kind of the last of the cases for discussion today. Any questions that anyone wants to bring up?
Oh, I have a question. Do you use the LRED score? Is that why you said ERPR was 4+?
So yeah, what is the all-red score? So the all-red score is a combination of that's mostly used in breast cancer, and probably Kamaljit could give us a better description of it, but it combines the intensity with the proportion of cells that are staining to come up with an all-red score. So I was just basing that on staining intensity and overall proportion of cell. I mean, it is sort of a composite of that. When I say 4+, it means that everything's staining and it's all pretty dark. So
Okay. Do you use that commonly in your breast report or GYN report, Kamaljit? I don't use it. I just use percentage
Yeah,
intensity.
gives you a bunch of options. So
Yeah.
you can use LRED score, but yeah, we give positive and then we actually give the details of the LRED score. So you can compute it from those numbers.
Yeah.
It's the proportion. We go in intervals of increasing in 10%. So 11 to 20 or 21 to 30, and then we give the intensity, weak, intermediate or strong, moderate or strong. And you can actually compute the LRED if you have both of those components. And yeah, as Dr. Hassel said, it goes on from 0 to 8. So I think 4 is pretty strong for serous.
Yeah, so so in the endometrium, I don't use the all-red score, but I would use a 1 to 4. So 4 is not my highest score in the endometrium, and that's why I said I thought it was inconsistent with most serous carcinomas, which would generally be 1 or 2 at the most in that setting. Well, we're going to post this recording onto the YouTube site for Open, as well as on my own personal channel. So if you want to refer back to this or take a look at any of these materials, you can do that. The slide deck is uploaded to the iEcho site. If you want to refer back to any of the materials there, you can also do it without having to listen through all of the talking. We'll meet again in a couple of weeks, and if any of you would like to volunteer to do a case presentation and work with either Esther or with Kamaljit on that presentation, we can do that. Anything that's sort of either in the basics of histology or in other sorts of QA processes related to workflow in pathology would be suitable for discussion at that time. But otherwise, we'll see you in a couple of weeks. Thanks, everyone.
Bye.
Thank you.
Thank you.